A topic of real interest to me as a deformity surgeon who again, as Rob says, operates in both domains. And so having done a lot of arthroplasty and things, and it's a very common referral to me from the local people where I live in Brisbane, Australia, to send me cases that they have the question, does it need deformity correction prior to knee arthroplasty, or can they just proceed straight with knee arthroplasty? The usual sort of disclosures and things that aren't relevant in this instance. I think that for me, it's something that I've had an interest in for a long, long time. I've been giving lectures on this for about 10 years. I love when you guys came out with the article that finally summarized lots of the things, I think, the ideas and concepts that we share in common. So, you know, when you look in the literature, other than the article that you guys have written in JAOS, everybody says you can just do an intra-articular correction. I mean, it's unbelievable when you look through the total joint literature that everything can be corrected intra-articular. And so things I can't really cover in this talk, and I'm really just going to focus on the decision making. But kinematic or balanced resection, benefits of navigation, yeah, it is better, believe me. Sagittal plane deformity, we won't be able to address. Limb length discrepancy, a lot of various other things, specific hard and fast rules. No, I'm not going to give you that. I'm going to give you what my impressions are. So intra-articular deformity can be either intrinsic or secondary, and there's bone loss or there's joint laxity. So these are the contributors to intra-articular deformity. There's also extra-articular deformity. And as the deformity people here would understand, this is something that is independent of the changes within the joint. So yeah, you can correct a lot of things with intra-articular asymmetric resection, augments, ligament balancing. You can do a lot. Now, personally, I've gone a lot to just going straight to a hinge, which solves a lot of those things. And really, patient satisfaction is much greater if you go to a hinge early. Extra-articular deformity, according to the literature, is really uncommon. It's about 1 in 1,000 total knees. I think that that may be because people just simply miss them. And my neck is very sore from shaking my head watching Austin's lecture before, because it's unbelievable some of the deformities that people miss. But is it femoral, is it tibial, is it combined, is it superimposed on intra-articular elements? Almost always. And we won't need to belabor the point here for this audience. Of course, the types of deformity, coronal plane, sagittal plane, oblique plane, or all the various elements of deformity, they all have a combined effect on alignment. And if you read the literature, if you just report your things in anatomical alignment, it always makes your results appear much more impressive. This is 25 degrees of anatomical alignment compared to 15 degrees of mechanical malalignment. So, you know, if you just report it on the anatomical measures, you'll sound like you're really doing some impressive corrections. So when you do these intra-articular deformities, yeah, you can correct it with asymmetric resection. You're ideally balancing this flexion gap and extension gap. And if there's some joint laxity, soft tissue releases are done as necessary when you look through the literature. And really, extra-articular deformity, and I know Chit Ranawat, certainly in the New York area and things, or around the world, he's recognized as one of the thought leaders in knee arthroplasty and things. Merrill Ritter, Mike Mott, all these guys, they've all written papers that say everything, literally everything, can be corrected intra-articular. Now I'll show you. This is a case that's a youngish sort of guy, 46, and he had a motorbike accident, had this sort of a bad injury. And I think this comes out to about 24 degrees of varus. It's not a terrible deformity. It's not awful. And in fact, there's a paper by Wang and Wang that published in 2002 that says you just draw a line straight up the shaft of the tibia, and if it intersects the joint at any point, then you're okay. You can just do this. And they report that they had no issues or problems. So when I do a knee, when I'm planning this, all I do is I make the 90-degree cut, as if you were going to make this, just plan out your resection. I don't measure the angles. I don't do any of that sort of thing. And I'm pretty sure this is what you guys have concluded in your article as well, that you plan to do a knee replacement with it in its current position and then make a decision, is that a sensible thing to do or not? And so in this instance, if I made a 90-degree cut across the top here, I'm going to end up with some sort of line like this. Well, I'm going to have a resection of this much bone. And yeah, you can do that. And it doesn't have to be a 36-millimeter resection. You can take off 18 and then take some bone and put an augment on the medial side. So if you took, you can get around it. But if you take off a 36 millimeter cut, well, you're going to have some issues there. Now you got to balance the ligaments and consider using a hinge or, is your patellar ligament going to avulse, all these sort of problems. And when you go through the paper, this Wang and Wang paper, they say that tibial deformities, you can correct up to 30 degrees. And the last guy was only 24. So they say you can add on to that. I mean, and beyond that, because the collateral ligament origins are always remote to where you do your osteotomy, on the medial side, the deep medial collateral ligament extends pretty far down, and on the lateral side, it's attached to the fibula. So they just say basically you can resect as much as you want of the tibia, as long as you don't take off the tibial tubercle. So they could correct a lot. And femoral deformities, you can only correct up to about 20 degrees. And there you have more problems with the collaterals if you do asymmetric resections and you start to lose the origins of the medial and lateral collaterals off the femur. So when you have these, for those of us that are very savvy in the world of deformity correction, obviously angulation alone is basically meaningless. If you just talk about angulation, because deformities have this angulation and translation element, and I think that, for instance, one of the ones that Austin showed where it was really dramatically displaced or translated, I think it was laterally, the shaft that had moved far laterally, you've completely missed all that. And so this probably helps to explain a bit of the literature of that all deformities can be addressed simply with an intra-articular correction. So can they all be dealt with the same way? And the real question for me is it the best way for all of them? Is there a better way for some of them? Can we make decisions about this? Are all extra-articular deformities the same? And how do we decide what we're going to do? Are we going to do a realignment osteotomy to delay things? Are we going to just do a primary knee? We're going to simultaneously do the deformity correction and the knee? Do we want to stage it, which I think is a sensible plan? Or do we want to do some kind of definitive procedure with a hinged knee? And so who do we select for these various things? So the short answer is, yeah, you can. You really can. Certainly, people have published that and people have done that. The question is, why would you? It's a very ugly solution. I think a lot of times you see some really strange decisions that people have made, and it's a lot easier to just straighten out the bones and then do a standard total knee. So are there a particular set of deformities that are more difficult to address? And that I don't have an answer for. But this is that paper, and I think it's well written, authoritative, and I agree with everything in here. And it's very consistent with the things that I've lectured on for years before this appeared in print. I think that when they went through their treatment algorithm as this decision tree, for some reason my brain just does not work this way. I can't go step, step, step. Like I'm falling down the stairs or a pachinko ball or something, and it just doesn't make any sense to me. So it's a bit of this. It's serial versus parallel processing, and for me, I don't think that way. And I know this also people may not necessarily think the way that I think, but there's really 5 key strategies to me. Are you going to do a primary total knee? Are you going to do a realignment osteotomy? Are you going to do a corrective osteotomy at the same time? Are you going to do a corrective osteotomy and then stage it and later on plan to do arthroplasty? Or are you just going to go straight to a hinge? And so if I look at it as a sort of PIAC, ROTA, COSA, SCOPA, and FAC, also, nobody thinks that way either. I mean, nobody is thinking this way. So I've instead translated into this sort of thing. Either I'm going to do it at the same time, the osteotomy, I'm going to correct the deformity at the same time, or I'm going to do it the next time. I'm going to do the knee the first time, or I'm going to do it as the last thing this guy ever gets, the last time. And then there's also this real time, which is realignment. And so how do you make a decision there? And so these are the things that really it comes down to for me. Physiologically, I don't care what the age is. If they're physiological, less than 55 or over 60, there's this gray area in the middle, of course. But we will look at it, sort of the various things that you can do. So the first-time guy, the first-time patient, these are the people that are physiologically over 60. And in the Australian Joint Registry, if you are aged 58 or more, your joint statistically will last you the rest of your life. So a lot of people in Australia like to say, oh, they are 58, okay, I'm going to do a total knee. Now, it's physiological age, really. And I look at it and say, if they could beat me in basketball, I look at the patient, looks like they could beat me in basketball, they're younger than me. It looks like I can beat them, then they're older than me. You always, you are the standard everywhere you look. You look around, you compare everybody to yourself. But for me, physiologically age over 60 and the small intra-articular deformity, they get an intra-articular correction. Small extra-articular deformity, they also get intra-articular correction. The realignment guys, the real-time guys, these are physiologically younger. They're less than 55. They get an osteotomy, they get an HTO or a DFO. The same time, these have a large, simple extra-articular deformity, something I can just crack the femur, straighten it out, put a long stem in, something very simple, straightforward. So diaphyseal and uniapical deformities, something very straightforward. I think that is reasonable to do at the same time. Otherwise, I'm going to do it the next time. So it's either same time or next time. If I want to do it next time, these are large deformities or complex deformities. They get stage correction, much of the ones that Austin showed you were these stage correction, or if they're multi-apical deformities things. And finally, this last time, these are the guys that they just want one operation. This is all they're going to need. You don't want to do a stage sort of thing. The guy's 78, 74, whatever he is. As long as a physiologic age over 75, they go, and I do it straight to a hinge without doing any sort of osteotomies pre-standing there. So other questions we could ask. The femur and the tibia, do they have different criteria? Yeah, I think they do. And a tibial deformity, for me, less than 20 degrees, it is reasonable to do intra-articular correction. Over 20, extra-articular. Then I'm going to do an extra-articular correction. The femoral ones, I think that for me, the decision is a much smaller one. And so if it's less than 10 degrees, they get intra-articular correction. If it's over 15, extra-articular correction. And do you have different criteria for femoral varus or valgus? You do. We won't have time to get into that. I almost always use a lateral approach now for all my revision knee sort of work. It just makes the patellar tracking much easier and more predictable, so almost all of them do. And most of them get a hinge now as well. Perineal nerve release I do if it's a combination of valgus, external rotation, and fixed flexion deformity is greater than 40 degrees. I add up all three of those things. If it's over 40, meaning 45 or more, then I do a perineal nerve release. So whether you approach it this way and do sort of parallel processing and try and figure out all these things all at once, or if you do it in this stepwise kind of fashion, either way I think is a very reasonable way. I'm going to show you just one case if we have time for that. And it's a 62-year-old guy with multiple deformities, hypophosphatemic rickets, and lots of osteotomies done as a child. He ends up with this big femoral bowing deformity, and he's got 18 degrees of this varus, mechanical alignment. He's also got this big procurvatum, and for him, it feels like his leg lengths are equal, and he's gone through a period of operations as a child to get his leg lengths equal. So he feels like they're equal, even though he's got these crazy-looking deformed bones. So for me, this is a complex deformity, and it's a staged correction prior to total knee. I think it'd be very ambitious to think you could just crack, straighten this, and then do a total knee. So we got 3 osteotomies, an IM nail, and I shortened them. I took out, because you correct that bowing deformity in the coronal plane, and I calculated out how much length he was going to gain, and so I cut that out. Now, it turns out that I forgot about the sagittal plane, and so I was straightening that at the same time, and he was still 2.3 centimeters too long, but and a little bit of residual varus, and that's okay, because I know I'm going to do this total knee at a later time. Unfortunately, he got this non-union. Not everything works out the way you plan it, so you get 1 osteotomy as a non-union. That's okay. I know that I'm coming back. This is a staged thing. We're going to deal with this, and now we've resected the additional bit of non-union and corrected its residual leg length discrepancy. We took the bone graft that was fresh from doing the total knee. We did a little lock plate there for that one remaining non-union, and I reconstructed his MCL with a hamstring transfer. And in the end, this is what I end up. So at the same time, he also had this rotational deformity from some of his other prior osteotomies he'd done as a child. And so even though I've got him to within 7 mil here, as an additional component of his deformity correction, I did the jiggly saw. This is a different patient. I don't have the photos of this guy, but you can do a jiggly saw corticotomy, basically. Slide through there, correct their rotation, and then just put a longer stem, and they heal pretty reliably. So I've had good success doing that, and that's about 3 months it takes them to heal up. We just have them walk. We don't change their rehab or anything. So in summary, Other things that you may want to consider, yes, Rob talked to you about limb length discrepancy. It's nothing that ever comes up with total knee replacement, but I think it is something that you have to consider in some of these complicated cases. And if you do big resections, you lose bone stock in young patients. I think that's not such a good thing. The geometry of the distal femur and how much stability you have with those flanges is an important element. And these other things, and I think that having stem extensions will run into the cortex, and so you need to plan that out ahead of time, what you're going to need. May need a custom implant for that. For me, finally, I think they do have different criteria. I think that for me, the decisions are based on not the angular deformity, but I picture how much resection I'm going to need to do a primary knee, and if it's unreasonable, I say that they need to have it corrected. And so for me, an unreasonable amount, a mismatch of 20 millimeters, less than 20, it should tolerate an intra-articular correction. If you take more than 25, probably greater than that, than what you can reasonably compensate for with soft tissue releases, then I do the extra-articular correction. All right, thank you for your time and attention.